Okay, so now we have our next speaker, which is Justine Graham. She's working as a perfusionist, as a pediatric perfusionist in San Francisco, and she's going to talk to us about a case report on in a pediatric cardiopulmonary bypass procedure.
Good morning, everyone. As they said, my name is Justine Graham. I'm a pediatric perfusionist in the UCSF healthcare system. I'm going to be talking to you about emergent pediatric resuscitation, systemic safeties and shortcomings, which is just a buzzwordy way to say I'm going to talk to you about an emergency management system we had, and then our analysis of our program's way that we responded to it and what went well and what areas we discovered for improvement afterwards. I have no disclosures. So emergencies, what are they good for? We are all aware that emergency situation management is an unfortunate reality of our career. As perfusionists, we have to deal with emergencies fairly frequently. They are certainly not enjoyable to deal with in the moment, but they offer a really great opportunity to learn about your practice and the systems that you have set up in it. And if you take the time after an emergency to really look at how your team responded, you can figure out what went well that kept the patient safe and what could have been done better and what you should change for the future. So we'll jump right in. We had a 4-week-old male with hypoplastic left heart syndrome with mitral and aortic atresia presenting for a modified Norwood procedure. He was a fairly high-risk patient, even within the normal high-risk area of being a Norwood. He was a low birth weight of 1,800 grams, and he had a bunch of other comorbidities. So by the time he got to us, he had already had full abdominal surgery as well. At 4 weeks old, he was only 2.4 kilos and 43 centimeters with a BSA of 0.17. The operation itself was very straightforward. We had an 8 French aortic cannula in the innominate artery and a 16 French venous cannula in the right atrium. We cooled to 20 degrees, arrested with a single dose of antigrade Pledgisol. Bypass time was 158 minutes, cross-clamp time was 72 minutes, and our antigrade cerebral perfusion or regional perfusion was 50 minutes. The case itself was very standard, very straightforward for us, and the patient came off bypass well, and our post-op echo showed no issues with the repair. Okay. So then we entered our first post-op period. Patient was stable off bypass, and once we were cleared by cardiology that everything looked good, protamine was given, and we reestablished our baseline ACT. And at that point, the team was just going through our normal post-op and post-Norwood. Should I just keep going? Okay. So we were just going through our normal post-op procedures. We were closely monitoring our post-op lactates and filling pressures. We were keeping an eye on our rate, rhythm, and EKG. We were working on, correcting our coagulopathy and fixing the bleeding at the field. And the patient remained very stable during this entire process of the operation. That's okay. Patient remained very stable during this portion of the operation. There were no signs that it was going to be problematic or we were going to have any issues. We got to the point where we were going to close, and the decision was made to leave the patient's chest open with a silastic patch. This is normal in pediatrics to leave patients open for 24 to 48 hours after a large case, just to give them extra time to rest and recover. So while the patch was going in, the lines were saved and handed serially back to the perfusion team. The pump was pulled back. We did notice a slight increase with our LA pressure as the patch was going in, but nothing that seemed that it was going to be a concerning level or like we needed to stop what we were doing. But then we did need to stop what we were doing because it was a concerning level. As the drapes were coming down, the patient acutely decompensated and ended up coding. At that point, the perfusionist that was on site and the ancillary nursing staff were in another OR setting up for a to follow case. So they were notified that they were needed back, that the patch was coming off emergently, and we were going to have to reestablish bypass. The lines had been sterilely saved, so they were handed back up without an issue, as well as new cannulas and connectors. The patient was fully reheparinized, and bypass was emergently reinitiated. Goal for the second bypass run was just stabilization and figuring out what had happened. We got on, stabilized, pulled our first gas, our lactate was 10.4, and everything else that you would expect from a first gas after a period of an acute decomposition. The circuit asked us to bring down the ECMO circuit and blood prime it. We weren't sure if we were going to be able to get back off bypass without it. And we also called cardiology back to have them echo again and make sure that there were still no issues with the repair that they wanted fixed or revised. While those things were happening, we had a discussion amongst all of the teams about the way that we wanted to manage the patient for the second bypass run. We decided to keep them warm, partially ejecting just to help rest the heart, and we continuously, pretty aggressively Z-buffed to get the lactate back down and to normalize all the electrolytes. This second bypass run was 155 minutes. Lactate came down to 4.7. The patient looked really stable overall. We handed the blood-primed ECMO circuit lines up just in case. We weren't able to get off bypass, but the patient again weaned with no issues. We hit our second post-op period, and it was a mirror image of our first one. Cardiology cleared us again. We all confirmed we were not going back on bypass if there was another issue. We were just going to go on ECMO. Patient tolerated being off bypass well. We again fully reversed the heparin, and then as soon as the patch went back in, the patient decompensated acutely and coded again. We did manage to reestablish circulatory function with a large bolus of epi and cardiac massage at the field, but we had to urgently place the patient on ECMO support at that point. So the patient went up to the CICU on central ECMO with an open chest just to help rest them for a few days. The patient was successfully weaned off ECMO post-op day 3 and then closed without any issues. And they otherwise recovered well in the CICU. And they were eventually discharged home. This patient's far enough along in their journey at this point that they've already successfully made it through their Glen as well. So this is a real success story for our team. So after this, we all sat down and talked about everybody's response to everything that happened. And we wanted to outline what safety things in our practice we thought really worked for the patient. The first thing for us was saving the lines. So it's common in pediatric institutions to save your lines sterilely until the patient leaves the room. It is different protocols from institution to institution. We personally save our lines for every patient. We had a precipitating event recently that made us decide we were saving for every patient until they left the room, no matter the acuity or the status. So our lines have been sterilely saved and handed back, and this allowed the perfusionist who was in-house alone at this point to be able to get the lines back up and get the patient on bypass with no delay from perfusion's perspective at all. Something that was special about this case was because we had blood primed the ECMO circuit and handed the lines up as well. When we were coming off bypass the second time, we had to have a decision or a discussion about whether we wanted to save the circuit lines or the ECMO lines. So the second time, when we had decided we would be going on ECMO if there were any other issues, we decided to save our ECMO circuit sterilely instead of the bypass circuit sterilely. So those lines were bagged the same way, handed back to us, and then the ECMO circuit was still sterilely available for us should we need it, which we did then end up needing it. You can see this picture off to the side. That's just how we save our lines. So they're double bagged in sterile drawstring bags and then handed back to us and just hung on the pump so that we can open the outer bag. The scrub or the assist can grab the inner bag, which has all the lines in it, and everything sterilely goes back up to the field. So as Susan was talking about earlier, we actually use the iPass, the clamp off, hand off for every case that we do. Our team has what I affectionately call a hybrid N+1 system. So for any portion of time that a patient is on bypass, we have 2 perfusionists in-house. But for the time period before and the time period after we come off bypass, we normally only have 1 perfusionist in-house. And that transition happens post-protamine. So our first perfusionist will come in, set up and pump the case. Their N+1 will be there while we're on bypass. And then once protamine is in, that first perfusionist will hand off control of the case to the +1 who then stays and finishes it. This often means that the person who's finishing the case is not the person who pumped it. which means that these handoffs are essential in our practice to make sure that the person who is finishing the case has all the information that they need to adequately and appropriately respond to any situation that they might find themselves in. So we have found that this handoff is very thorough, and having it standardized means that we don't miss information when we are transitioning from care from one perfusionist to another. So in this case, the +1 perfusionist felt comfortable crashing back on bypass with this patient that they had not pumped the case for because they had all the information that they needed from their handoff. We also had some communication things that worked really well for us. So Tammy was talking yesterday about communication amongst team and how important it is, and how there are a lot of platforms that exist now for really good communication. Our team uses WhatsApp as our primary communication form. We have a group chat that has everybody in it. So this allowed the perfusionist that was in-house alone to be able to just send out one single message that said, emergency, I need backup. It went to the whole team. They weren't having to go through and pick out certain people, contact multiple people, and make sure that they were getting the message to everybody that they needed to. Additionally, our nurses are aware of how our staffing model works. So once our lines were going back up and our cannulas were going back up, our circulating nurse came over to our perfusionist, asked who their backup perfusionist was, and then the circulating nurse called them, got them on the phone, was able to tell that perfusionist what was happening, get an ETA for them, and just close the loop that we did definitely have a second set of hands on their way to the hospital to help with everything that was going on. And then finally, we had really close communication with our surgeons the whole time. We took the pause once we reestablished bypass to discuss what the plan was, how we wanted to manage the patient. Were we going to stay warm or cold? Did we want to eject, or did we want to fully empty? Did we want to Z-buff or let the patient level out on their own? And then when we got closer to coming off bypass, we again paused to discuss what our plan was. What were we going to do with the ECMO lines? What were we going to do with the ECMO circuit? If the patient managed to make it upstairs not on ECMO, the circuit was already blood primed and it was going to expire. Did we want that circuit to travel with the patient until it expired? So we took a lot of time to pause and appropriately communicate with each other to make sure that there was nothing getting lost in communication, and we were also staying ahead of other potential emergency issues that we might run into. Finally, we have fully stocked emergency carts in all of our cardiac ORs. They have every cannula that we carry, all of our drugs, all of our connectors, and pretty much any other ancillary equipment that we could potentially need in an emergency situation. We are very on top of making sure that they stay fully stocked at all times. This allowed the perfusionist who was in-house alone to get back into the OR and then not have to leave again. Once they got back in and they were handling this coding situation with this patient, everything that they needed was in this cart. They were able to hand up new cannulas, new connectors, grab drugs, grab fluids, and at no point did they have to leave the patient alone in the OR to try to go grab other supplies. What could go better? So there were a lot of things that went well that we were very happy about, but we did definitely still find some holes in the system that offered room for improvement. One of them was our heparin dosing. So this patient received a lot of heparin. 2.4 kilos is a very small child. We did an additional full loading dose of 400 per kilo. I would imagine that's pretty standard across the field. Nobody wants an under-heparinized patient in an emergency situation, especially when you're not running an ACT before you're crashing back on. But because of the way we save our lines, we actually save our circuit fully blood primed. So we put an additional 2,000 units just circulating in our pump to make sure that we maintain the patency of our pump the whole time the patient is in the room. So in addition to this 400 per kilo bolus that they got from anesthesia, they got an additional 2,000 units from the pump, which was actually roughly double their loading dose. It was a lot of heparin that this patient received. Because of that, and because of the fact that they had already undergone a deep hypothermic case just a little bit beforehand and their coagulation was still a little off, the ACTs on our second bypass run were all unreadably high. There was no change to them for the entire 2.5 hours we were on bypass. Even though we were fully warm, the patient was not metabolizing the heparin at any sort of readable level. And we discovered another hole was that there was no discussion during this time period about whether we should give more FFP. It's obviously very common in pediatrics to prime with FFP and then to give more FFP on the rewarm just to help correct some of those factors. And that likely would have been helpful in this situation to help with this ACT that we were having trouble getting back to a readable level, but that was just never discussed amongst the team. The main reason this was a concern was because the surgeons were not sure that we were going to be able to get off bypass without needing to transition to ECMO. And obviously transitioning to ECMO with ACTs that are unreadably high presents a really high concern. Can't use your suckers on ECMO. And if we can't have the bleeding under control of the field, it's going to be a real issue. The surgeon at one point questioned actually giving a small dose of protamine while we were still on bypass, which was shot down very hard, and thankfully they listened. But we had to have a pretty serious conversation amongst all the team members about what our plan was to manage this patient's bleeding risk if we had to transition directly to ECMO with the coagulation level that we were at. Did we have enough products available? Were we going to be able to support this patient through that? We also discovered just an overall lack of actual hands-on emergency practice within our team. In our institution, it's very uncommon to need to crash back on bypass. The majority of the emergencies that we deal with are ECMO related. If we're getting called in for like a true emergency, it's usually in the unit and it's usually ECMO. That means that the habits and the practices in place for most of the staff members are all ECMO related. There is obviously crossover between an ECMO emergency and a bypass emergency, but there are things that are unique to each as well. One of the things that we discovered was problematic was that the heparin bolus almost got missed. The purse strings were in, the cannulas were going in, the perfusionist was going through their emergent reestablishment of bypass checklist. They confirmed that the heparin had been given, and it had in fact not been given at that point. So then everyone was flustered, the cannulas are going in, and we have not given heparin. So at that point, there was then miscommunication between the anesthesia and the surgeon, and we ended up giving the wrong dose, and the patient got extra heparin, even more than they needed at that point. They ended up getting 1,200 units instead of the 960 that they would have gotten, which was obviously problematic when we were already concerned about the heparin level of this patient. This was also the first time that we had ever actually had to hand our lines back up in this new system. We had implemented it, but then never actually practiced the logistics of it, which we discovered was challenging. Thankfully, the lines got back up, but we definitely discovered that there wasn't a set method for everybody to follow. All the scrubs tied the bags differently. Some of them double knot them, in which case you're trying to find a pair of scissors to cut through the drawstring while you're trying to hand these lines back up. So it just showed us that in the future, we definitely need to be making sure that people are getting hands-on logistical practice when we implement new things, instead of just implementing them and then having people having to deal with that potentially for the first time in an emergency situation. The last thing we discovered was a lack of a really established protocol for us. So we have a very general emergency establishment of bypass protocol, but it was aimed more at establishing bypass in an initial emergency than emergently reestablishing bypass. Again, there's a lot of crossover, but there are things that don't directly cross over as well that were not well delineated. So there was nothing in the protocol about the lines going back up. There was nothing in the protocol about drugs and redosing in the pump. Do you need to give an extra dose of antibiotics? Are we redosing mannitol? What are we doing about all of our drugs? None of that was clearly delineated. There was nothing in there about FFP redosing, like we had talked about earlier. There was also a lack of any acknowledgement of what the other teams are going to be doing as it could potentially relate to you, checking to make sure that the heparin has gone in, making sure that you're handing new cannulas up because the surgeon needs new cannulas and new connectors if they're doing all of this. So it just was an option to have a really thorough debrief as a team, look at the protocol as it existed and figure out where we could go with it to make it safer and stronger for everybody moving forward. So moving forward, our lines are still saved for every patient. After we initiated this new saving the lines for every patient, we actually received a lot of pushback from the scrub team and the surgeons because it required a change to their workflow. They cut the cannulas out, they put connectors in so that we can recirculate through the AV loop, and it's an extra 90 to 120 seconds that they had to account for in this post-bypass period that they didn't normally have to before, and they did not enjoy that. So this was a really great opportunity for us to point to this and say, hey, this really helped this kid. This really kept this kid safe. We need to be doing this for every patient, no matter what. We also have placed a lot of emphasis on making sure that we have fully discussed logistics for everything before we implement a new practice. So we do our best to make sure that everyone has some hands-on experience with doing new things before we just implement changes to the practice in general. We also discussed the heparin and the FFP. We had a discussion about whether we should change the heparin circulating dose or the loading dose to the pump. Ultimately, we decided no. It was obviously a problem for just this one patient, but we decided it is more concerning to lower all of that and then be under-heparinized in an emergency. So it's just something we flagged to watch moving forward as we find ourselves in these situations again. The FFP, we decided, needs to be a conversation for every single patient. So every time that we might need to emergently reestablish bypass, once we get on and stable and pull an ACT or two and see where our coagulation is trending, we then have a conversation with anesthesia, with the surgeons, about if we think we need to be correcting the FFP, correcting the factors, and having a conversation about that. And then finally, we're working on organizing semi-annual and annual emergency drills with the team. Hands-on stuff is helpful, but even just sitting down and talking through potential problems and the way that everybody would respond to them is really helpful. Obviously, it's much easier to do from just a perfusion-only perspective, but if you can get multidisciplinary emergency practice planned, it's very helpful. Our cath lab does mock ECLS codes that they require every team to attend, and it's really helpful to have those established patterns between all of the teams available for reference. So the takeaways: emergencies are never ideal. Obviously, nobody enjoys dealing with them, but they are an unfortunate reality for our job, and they can be an excellent source of information for your team about potential practice changes for improvement. Debriefs amongst all team members are really important afterwards, both within your perfusion team and within every team that was present. Talk to your nurses, talk to your scrubs, talk to anesthesia, talk to the surgeons. Every team experiences that emergency through a different lens. All of them had different priorities while it was happening. So you want to make sure everybody's on the same page and that nothing gets missed between any team member, so that all of the team is responding as well as you can to these safety emergencies. So finally, analyzing emergencies and adverse events after they happen can provide really great starting points for your practice and safety improvements at your institution. That's it. Thank you for your time.